board the bus by 5:15. And the last session for today is Professor Pichumoni LivingLegend Symposium. I invite Dr. Girija ma'am for opening the session.
Good afternoon, everybody. Now, new emerging and re-emerging and deliberately emerging infections are now entered in the vocabulary of medical science, and no year is passing without announcing a new disease in some parts of the world. So we have, with the relevance of that, we have selected the topic, newer concepts and practice guidelines for the symposium. The symposium is under LivingLegend Symposium. The living legend is Dr. Pichumoni, sir. Sir, please, I request sir to take the seat on dais. And I also invite the chairpersons, Jayamarsi, Manjusri, Remani, Dr. Remani, Vasudevan, Geeta S. Please be seated on the dais. And the moderator, Dr. Aravind, Associate Professor, Department of Infectious Diseases in Trivandrum Medical College. Please, Aravind. So I request Aravind to introduce the panelists, and Shija Sugunan, Rajalakshmi, and Sharada Devi. Come to this. Over to Aravind.
To thank the scientific committee led by Vinay Kumar sir, my teacher Sima madam, and Kavita madam for this opportunity. As the previous two speakers alluded, in the era of emerging evidence, the basic concept is about the team approach. So basically for diabetic foot, he stressed on the need for a team approach. For sepsis, the team approach. Like that, for the next 45 minutes, we have an eminent panel. This comprising of Dr. Rajalakshmi madam. Dr. Rajalakshmi madam, she is actually the consultant of she is the lead consultant of infectious disease at KIMS Health. Then we have Dr. Shija Sugunan. She is the additional professor of pediatrics and takes after the pediatric critical care at SAT Hospital. And then Dr. Sharada Devi madam, the retired head of Department of Microbiology at GMC Trivandrum. So we will start the proceedings by taking up the problem of antimicrobial resistance. As we all know that, so whenever we talk about infections, the treatment of infections of any infection is actually complicated by the development of antimicrobial resistant infections. So my first question will be to Dr. Rajalakshmi madam. So when we talk about infections, the first thing that crosses our mind is the scourge of AMR, which is actually described as the silent pandemic. A lot of conceptual changes has occurred in the last decade with regard to the understanding of genesis of AMR and the need for stewardship. Being an expert on antimicrobial stewardship, can you elaborate on the newer evidence on antimicrobial stewardship, which has led to a paradigm shift in the way we approach infections and how we prescribe antimicrobials? Over to you, madam.
Thank you. Am I audible? Yeah. Thank you. There's a lot of focus about antimicrobial stewardship that can be done at any level. Yeah, I think I'm not audible. Can be done at any level, and we know that Kerala is a leading state in doing antimicrobial stewardship both at the public and the hospital level, and it's been widely acclaimed. And the simple mantra for us is start smart and then focus. So we know that clinicians will have a lot of inhibitions in withholding an antibiotic because if this comes as a febrile syndrome in ER, sepsis will be one of the differential diagnoses. So starting smart is about having an ID syndrome and starting an antibiotic if required. that is okay. Then comes the focus. So we then focus on if it is an infection at all. So we get the results in 48 hours. And then you plan a therapy. Focus doesn't mean just using the antibiotic, but then the next step is the duration. So we have now a lot of evidence to show that shorter durations are better, and it is also easy to convince a clinician once they start antibiotic for a syndrome to stop at a shorter duration than withholding an antibiotic, because we are also convinced about antibiotic that's required, but now the duration of antibiotic is very much defined. Like we are going towards shorter therapy for pneumonia, 5 days, pyelonephritis. If there is source control done, like an obstruction is relieved, it is about 7 to 10 days. If the response is slow, probably they will require a longer therapy. Even in certain gram-negative infections, where the response is slow, it is up to 10 days, and in certain cases maybe up to 14 days, like ventilator-associated pneumonia, which is not resolving. And we have a lot of published data for this, and there's a beautiful study done by Valerie, and later it is proven even for gram-negative infections, certain infections like E. coli for pyelonephritis, short is better. So we have evidence, there are a lot of RCT, so it is proven that shorter is better. And then discharging the patient home early. That is also a stewardship that we can do. Then complete the IV antibiotic in the hospital. That's the most important thing, because they are in the hospital environment. So we are looking at two important things. One is outpatient antibiotic therapy, IV antibiotic therapy. Then second is outpatient oral antibiotic therapy for complex infection. My previous speaker mentioned about OVIVA study. It's a beautiful study where they looked at oral antibiotic therapy for important joint and bone infection, for which the usual duration is up to 12 weeks. Now shorter duration is recognized and approved, and for certain bacteria which we have good oral options with a good bioavailability, like quinolone, linezolid and so on, certain proven, culture proven infections with good oral bioavailability, we can switch to oral at 2 weeks, and there are enough trials to show and follow-up trials to show that the cure rate is better, the readmissions are as comparable to IV therapy. So we are looking at starting smart, then focus. That means at culture you review whether it is an infection, and then moving towards to shorter regime, OPAT and COPAT, that is complex outpatient antimicrobial therapy. That is the in thing now in ID, that means stewardship in ID. So, and it is possible at least for at least 10 to 20% of complex infection. Even in endocarditis, we have a beautiful study called POET study, which means that for certain infections in the left ventricular infections, valve infections, where there is a susceptible strain, where oral options are available, and you can use a defined regime after excluding the high-risk group. So this is possible. Even last week I discharged a patient who had a left-sided endocarditis, aortic valve, and who had culture-proven Enterococcus fecalis. So 2 weeks of IV therapy, I calculated his weight, and he is all coming into the low-risk category. I switched to oral, amoxicillin plus moxi, and he's doing well at 4 weeks. So, so these are possible, and this actually helps in recovery. Cost benefit is more, and definitely that's one of the stewardship that we can all think. This is all de-escalation. So IV to oral is also called de-escalation. And broader to narrow spectrum is also de-escalation. IV to oral switch is de-escalation. And it has a lot of cost benefit also. Patient satisfaction is immense.
So thank you, madam, for taking us through the emerging concepts of antimicrobial stewardship. And now the second aspect is which was been discussed in detail by the previous speakers when he touched upon the another target which is emerging, that is the immune modulation in the treatment of sepsis as well as other infectious agents. Interestingly, Yale University of Immunology came out with a public health statement last year saying that following COVID, so this was to explain long COVID symptomatology, the following COVID, there is an alteration in the immune system cells of majority of the patients, and you can see that majority of us, our stem cells, etc., migrated to a pro-inflammatory phenotype. The reason why, there is an increase in autoimmune as well as autoinflammatory conditions, which was observed following 2022. This is the Delta wave. So in this context, I would like to ask Shrija Madam, who is a eminent pediatric intensivist. So after recovery trial, there has been a paradigm shift in the way we manage infection. So we know that in recovery trial, the mortality benefit was actually observed with immunomodulators like the steroids as well as the IL-6 inhibitors like tocilizumab and the JAK inhibitors. So following this, immune modulation have emerged as a very important therapeutic target. So with your immense experience in the management of multisystem inflammatory syndrome in children as well as part of the team which formulated the Kerala state guidelines on influenza-associated encephalitis and primary amoebic meningoencephalitis. So please take us through the importance of immune modulation as well as the importance of critical care in salvaging patients with sepsis.
Thank you, Dr. Arvind. So I think that's very important point was highlighted by the previous speaker itself, that when it comes to sepsis, it is not only the organism that is going to kill, it's also the way our body is reacting to the organism also contributes to the morbidity and mortality. And that is, I think, highlighted, as Dr. Arvind already said, in the recovery trial. And we recently have the Cape Cod trial, that is trial for community-acquired pneumonia, severe community-acquired pneumonia patients treated with steroids. So here what they found was there was a great mortality benefit in the subgroup of patients who were given hydrocortisone at admission for 4 days, followed by tapering for 8 to 12 days. So basically telling that there is an immune dysregulation happening there or a hyperimmune response. But if you really look at the subset of patients who really benefited by that steroid, in the paper you would realize that it is those patients who had a CRP more than 15 per deciliter. So that basically means that those subset in whom the body was reacting too much abnormally was the one who was benefited by steroids. So further studies need to come. There are also certain other situations where we are thinking of immune modulation. Immune modulation in the sense, in some situations like immune paralysis is happening, you may be boosting up the immunity by giving an immunoglobulin, or in some situation may be going for an immunosuppressant also. So one of those examples is definitely influenza-associated encephalitis. We had an outbreak in 2019 and we continue to get sporadic cases even now. So we all know encephalitis is a killer disease. If it's very bad, that means mortality is definitely high, and the mortality happens because of an uncontrolled intracranial pressure leading on to brainstem herniation. In that subgroup of patients who are influenza-associated encephalitis, definitely immunomodulation has a mortality benefit. Now, coming to children with or adults with amoebic meningoencephalitis. So here I would say that we had 8 cases of amoebic meningoencephalitis in the last 5 months, out of which 4 were not sick, they just needed an HDU care. 4 were really sick and landed up in your ICU, and out of that 2 was very sick and needed very intense ICU care, including ventilation for a prolonged time and induction of coma with thiopentone for close to 8 days. But when we analyze these patients, when it comes to primary amoebic meningoencephalitis, what made that 2 children who were really bad different from the 6 others was not exactly immunomodulation, but that was a starting of the treatment early. When we analyzed the 8 children, we realized that the 2 who really became bad were the ones who received the miltefosine regimen after 5 days, and all others had received before 5 days. So in short, we would say that we are moving towards looking at optimizing the antibiotics. We are also moving towards looking at how our body is reacting to the organism and probably doing an immunomodulation also.
Madam, can you also comment on the changing epidemiology of mycoplasma pneumonia with the emergence of macrolide-resistant mycoplasma pneumonia, as well as the role of steroids in the treatment of refractory mycoplasma pneumonia?
So regarding mycoplasma, we were all taught in our college days that it was a walking pneumonia, which is not the case anymore. Because last couple of months, we have really had an outbreak of mycoplasma, not only in Kerala, but in many parts of the world over also. And this time it is not a walking pneumonia. A significant proportion of patients land up in the ICU, get ventilated also. They manifest not just with pulmonary symptoms, they manifest with extrapulmonary symptoms also. Pulmonary symptoms itself are quite grave because that is why they are landing up on your ventilators. And what is this thing is that a significant proportion were having macrolide resistant. And another group was definitely responding to doxycycline, but that group which landed up on the ventilator or critically ill or on whom the fever persisted beyond 7 days without being too sick were the ones who had very high LDH levels above 1000. And this subgroup of patients definitely they respond to a short course of steroids. They don't require very high immunomodulation. They just require a low dose of steroids for 3 to 4 days. That is enough. So definitely in a mycoplasma infection which is refractory to macrolide and probably doxycycline, we need to think about immune dysregulation. We need to think about steroids in that case.
Thank you, madam. So without the right microbiological diagnosis at the right time, it is very difficult to optimize the treatment of infections. Last decade has seen the emergence of a lot of newer methods in the diagnosis of infectious disease. Sarada Devi madam, can you take us through the latest modalities which has helped in diagnosing infections at the earliest?
So first of all, one word about pre-test probability. Always the clinician will be examining the patient and he will come to a conclusion. All his senses will be acting. What is this? What is the history? Whether there is a travel history or is it undifferentiated febrile illness? All this he will have a clue. So please, or he has got an underlying disease, then all this has to be recorded in the requisition form. That is a very much important because ID physician or clinician has to always discuss with the microbiologist and then come to a conclusion. So the diagnosis, how the clinician has come to the diagnosis. So what is the site of sampling, what is the sample that has been taken, what is the clinical diagnosis, underlying condition, all this is very important. It's a clue for the microbiologist. So let me just talk about sepsis. If you are suspecting sepsis, what we do was blood culture will be taken under strict aseptic precautions. Blood samples will be collected. We will be doing culturing, and then after the growth has come, it will biochemical identification, AST, all this was done, and it will take more than about 72 hours to get a result. Now rapid test has come. For example, if you send it is not just, now we have shifted to automated blood cultures. So when automated blood cultures are sent to the lab, immediately if it's really sepsis, and sepsis we have to give antibiotics within 1 hour if the patient is in septic shock. So what do we do is, we have to, the conventional method, definitely you have to send blood before the antibiotics, otherwise false negative blood cultures can occur, because starting of antibiotics, and if it is a fastidious organism or a non-cultivable, you will not get in your conventional method. So you have to go for your, what we do now in Trivandrum Medical College, I will just tell you what is the era that has been changed. For example, if blood culture, we have now not conventional, we have got automated blood culture. Automated blood culture, when it flags positive, if it is not, antibiotics are not given, flags positive, immediately we have got Malditov MS available. But it is the limitation of Malditov is that it is the initial investment is very high. To buy that machine, you need crores of rupees. So only Malditov is available only in one of our government institutions. Why? Because of a AMR project with the NCDC, central government has given it. The limitation of and the success is that you can immediately identify the organism. You would only just 15 minutes you need, or blood culture positive, you can identify it, and immediately the patient, they can start but you don't get ASD, antimicrobial susceptibility testing results. We will not get, only identification. If you identify the organism, what you can do is that you can, based on a local antibiogram, you can change the antibiotics. You got a local antibiogram, the institute has got an antibiotic policy, you can change accordingly to it. Now coming to, this is the method that we do, but we have to get AST also. For that you have to need a growth. So after the organism grows, we have got Vitek 2, where you get ID as well as AST. So now the time has been reduced from about 72 hours to about 48 hours you can give. And this is, here again in this method also, antibiotic, if they have started, you get a false negative blood cultures. So now we are going to move on to molecular methods. You got NAT. nucleic acid testing as well as next generation sequencing is there. But next generation sequencing for blood sample, there is just a caveat is there. You cannot, because of blood contains human genomic DNA is more than your microbial DNA. So in that case, you have to go for microbial cell-free DNA processing only in the case of blood. Other samples you can straight away go for your NAT or NGS and you get your result fast. And directly from the whole blood also you can do a T2 panel. That is, you have got a T2 bacteria panel or a T2 candida panel. Bacteria panel you can detect E. coli, Klebsiella, Acinetobacter, Enterococcus faecium, Staph aureus. In that, in T2 candida panel, directly you can say whether it is Candida albicans or it's tropicalis or parapsilosis or it is cruzi. You can diagnose the Candida species also. So now we have come to molecular methods by which fast identification is possible.
Thank you, madam. So what madam said is that no, without the help of a very strong lab, it is very difficult to optimize the treatment and to optimize the stewardship activities. So next is to Dr. Rajalashmi. So the current era is that of precision medicine. So now without knowing the resistance mechanism, it is very difficult to optimize antimicrobial therapy in ICU where the carbapenem resistance among enterobacterials is more than 50%. So can you highlight the importance of knowing the resistance mechanism while selecting the right antibiotic? And in desperate situations like say PDR or XDR bugs, researchers are looking beyond antibiotics at newer therapeutic targets like the phage therapy, etc. So first of all, can you throw light on the importance of knowing the resistance mechanism while selecting antimicrobials in the ICU?
So in this era, it's becoming more and more important not only to know the pathogen but also the resistance profile. Because your susceptibility results, as madam says, tells that it takes 72 hours. Okay, but your appropriate therapy for a patient who is in sepsis should be decided in few hours. So you may give an empiric therapy of a broad spectrum or 2 drugs, but then it is always important that you diagnose in the next 6 hours or next 24 hours or 36 hours at the earliest to know what is the right appropriate therapy, so that you give the right drug, targeted therapy, and you reduce the unnecessary drugs. So this is now possible with the test that madam has beautifully explained. So molecular test is useful, one, to diagnose a resistance and to give the right targeted therapy to improve the outcome. Number 2, it also is important to know whether it's a drug resistant bug and whether this patient needs isolation before there is an outbreak and a huge transmission. And in this era, we know that by doing certain tests, there are expensive tests, there are very simple, cheap tests like MALDI. What madam said is very cheap, 200 rupees. Only the instrument investment cost is high. So with that, we go for susceptibility or no. Second is to know directly the drug resistant bugs. So if your blood culture flags positive, take a drop of blood and run in a machine which detects the resistant gene as well as the bug. That's a beautiful test that we have, though it is expensive. But in septic patient, it is definitely a useful test because you will know whether you have to use the newer drugs. So in India, the most common carbapenem resistant genes that we find is either NDM or OXA or a combination of these two. So by knowing this, whether it is NDM, we know that we have only few options of giving ceftazidime, avibactam, or plus aspirin, which is a newer drug, or polymyxin. These are drugs that will actually be used upfront in a patient. But this is not the drug that should be used for everyone. So in such cases, this is definitely useful. But you should remember that ceftazidime, avibactam, and aspirin is now being widely used, as I understand, in many centers as empiric therapy, and we are soon going to lose a drug. It is actually a narrow spectrum drug. It is useful for CRE, Klebsiella, and it's used in combination with aspirin. But if you use for E. coli or Pseudomonas, there is a good chance that it may be resistant. It doesn't have any anaerobic cover, though it has avibactam as a beta-lactamase inhibitor. It has no gram-positive cover. So understanding the resistance, choosing the right drug is becoming more and more important in this era of drug resistance. And for this, the precision medicine is very, very important. Like you have to, if the blood culture flags, you should understand that for this patient, this panel of running a PCR will be useful, and actually we may save some cost by reducing the number of antibiotic, and definitely may even save life. So in such cases these tests should be chosen, used, and we should not throw multiple antibiotics empirically for an indifferent period. There should a time period, probably 1 dose, yes, but in the next 24 hours you should be able to understand whether it's a GNB, what is the next step, whether we can use this PCR, and then based on the resistance, like if it is NDM, we can choose this drug. If it is OXA48, probably we can choose this drug. If there is no resistance, only a CTXM, that means it is ESBL, probably we can stick on to carbapenem. So all these decisions are actually difficult for any clinician to make, but we have to understand that it is becoming very complex. Please make use of your microbiologist who is in your center. They will definitely help you, or an ID physician or a physician trained in ID, or who handles ID, because this makes a huge difference in the outcome of septic patients. We are actually losing a lot of ICU patients in the first few years because of inappropriate antibiotic choice, and these are not seen as a major problem worldwide, and definitely it is called the silent pandemic. We'll have to understand it's a big issue.
Madam, in certain situations, you do face PDR as well as XDR bugs, so where your antimicrobial combinations may not be an optimal choice. So there are a lot of research on other targets as well. Can you throw light on that?
Yeah. So first thing is that if you have an antibiotic and it's not working, please look at whether the drug sensitivity is appropriate and whether we have used to maximize the PK/PD of the drug. That's the most important thing. So you may be giving a suboptimal dose in you may not be giving as infusion. Like for beta-lactam, it has to be given as 3-hour infusion. That maximizes in a septic patient that PK/PD. So that is important, and monitoring the drug level by TDM. That's in thing for certain antibiotics at least. We have to use for vancomycin, and for certain countries they have for other antibiotic also they are using therapeutic drug monitoring and adjust the dose, especially if the patient is on renal replacement or is an ECMO. But it is not available for all drugs. Then we have to think about experimental therapy. So there are a lot of experimental therapy that is in research model, but we have not it's not available in market majority, except for maybe a trial of bacteriophages, as it's mentioned in this beautiful picture. So phages is coming in a big way. So it can be used for a single pathogen, or if it is a biofilm where you have to use these phages, it can be a combination lytic phage. Like for best example is the last session on diabetic foot infection, where biofilm is the major problem. For those in drug resistant bug, you don't have any options. You do a good source control, like debride as much as possible. Then phages it can be personalized. It's a personalized medicine. Phages can be made for that particular bug, and definitely it may have a role. Again, in prostatitis it has been tried, and biofilm effect for all this it has been tried. Other novel therapies are nanoparticles, that is nano antibiotics, which is all antibiotics in very, very millimeter size, which is actually can enter the bacteria and have a very good effect than the normal antibiotic, that capsules that we use. And of course there are monoclonal antibiotics which is tried mainly for viral infections, COVID, influenza. There are trials, and more and more now there are studies on other viruses including dengue and Zika and so on. But again, drug resistance is not a big problem among the viruses. Then we have virulence, anti-virulence factor. That also is a research molecule where you reduce the virulence of the bacteria by modifying the genes and so on. And then the CRISPR technology, where you actually do some genetic modulation so that the bacteria loses its virulence or the resistance. Sorry, not the virulence, the resistance. Vaccines are still, we don't have, it's still a research model, experimental model. We don't have vaccines for all the gram-negatives that we have, which is a huge problem. We have mostly vaccines, as we know, for pneumococcal and other bacteria, in which again resistance is a problem. We have a lot of pneumococcal resistant, ceftriaxone resistant pneumococci creeping up. But for Klebsiella E. coli, again, vaccine will be if you get a vaccine, everybody will run for, because that is the amount of big problem that we're facing. Vaccines are again a research thing. And fecal microbiome, that's an important thing that is also coming up. So we know that our microbiome is modulated by probiotics, prebiotics, and then with C. diff we know that introducing a new microbiome from a different patient actually can help treat Clostridium, so Clostridium difficile. So with that, there are other researches that was done with a fecal microbiota transplant, more so in inflammatory bowel disease like Crohn's. So it has come a big way. And probably microbiome modulation is also important and maybe a possible way for future therapeutics. And it can be a multi-pronged approach because we are running short of antibiotics, and a lot of research are happening in all these treatment modalities.
So vaccines are time-tested tools to mitigate the impact of infection. So we are going through an era where we have access to a lot of newer vaccine candidates and vaccine platforms against a variety of pathogens. So as an eminent expert in the field of vaccinology, I would like Shrija Madam to take us through the recent strides and the challenges.
Basically, vaccinology, yes, it's undergoing a lot of new development in that field. And I think major thing is we all know that recently we have more new platforms of vaccine. That is during the COVID time we came across the vector vaccines, the mRNA, the DNA vaccines we came. And now we also have vaccines for age-old diseases. That is now you have a licensed vaccine for dengue, you have a licensed vaccine for malaria. Then of course, now what you're again looking at is vaccines to be administered to the mother so that the mother is transferring the antibody to the baby and baby is protected. And that is the MATIS trial for RSV. And it is already in the market, not in Indian market. It is being advocated by the CDC and currently being used in the Western world. That is the last trimester of the pregnancy, mothers are given RSV vaccine, and that protects the newborn for up to 6 months to 1 year against RSV infection. And similarly, a vaccine against group B streptococcus, similarly to be administered to the mother to protect the newborn from GBS sepsis in the postnatal period is also phase 2 trial, not exactly phase 3. But what is more interesting in the third part would be vaccines with therapeutic, which Dr. Alakshmi mentioned about it. It's not come a big way, but definitely for tuberculosis, many of the vaccines are currently in phase 3 trials and we can expect that to be coming. So you are not exactly looking at completely prevention of an infection. Newer vaccines are looking at how to prevent a disease. That means vaccines that can be administered to manto-positive people to see that the latent infection is not being progressing to the disease. Similarly, already there is one vaccine which is launched in China. They are currently using it to shorten the duration of anti-tuberculosis treatment. So I think in the coming years or the coming era, definitely we would see more and more vaccines and vaccine platforms.
Madam, what about the possibility of having a universal flu vaccine or a COVID vaccine?
Right now it's difficult to say because naturally the flu keeps changing. With H5N1 also we are expecting that to come soon, but I think it would be a little difficult at this point.
Actually, what Madam said is true, but because of the AI platforms and all, now they are coming with something known as a COBRA technology. COBRA means computational analysis of broadly reactive antigens. That means that they looked at the stored sequences of the influenza over the last decade or so. They looked at around 10,000 sequences and they identified the concerned amino acid sequences. And this universal flu vaccine is in the phase 2 to phase 3 trial. Like that, the universal COVID vaccine also might come up. And regarding the MATIS trial, one important aspect was that you take on the immunity depth concept, madam? Immunity depth and the increase in pediatric infections. Okay. So after 2022, that is after the Delta wave, so there was a huge surge in the respiratory infections in all age groups, especially in the pediatric population. And one theory was that, since the mothers were protected, so there was no chance of a natural transfer of antibodies to the neonates and infants. And that is how the MATIS trial, the concept came about. That is, you are immunizing the mother so that you can protect the neonate from severe RSV infection. So now coming to our major concern.
Can I add something more?
Sure,
because basically it's not only that, we also need to know there is something called a trained immunity. That means sometimes a vaccine being given protects you against diseases which are not related to the vaccine. That was also a big discussion during the COVID time, that why children are not getting much severe and why children in the developing countries are not getting. Is it because of the BCG vaccine that we give? But there have been subsequent studies which definitely multiple studies which have said that babies who are vaccinated with BCG in fact has a lesser mortality due to neonatal infection due to varied causes. So giving a vaccine early in the life is in fact priming not only your adaptive immunity, is priming your innate immunity to make you fight better other diseases. So other side of the immunity.
Sure, madam. Okay. So our major concern is always the threat of emerging infections or re-emerging infections in Kerala because of its peculiar epidemiological vulnerability. So we are at increased risk of emerging infections, and identifying disease X at right time is a very crucial part of outbreak response. Sarada Devi madam, please highlight the importance of syndromic versus targeted testing strategies in diagnosing emerging infections. Also, whether the current molecular platforms available to us in Kerala, will it be sufficient enough to help us in diagnosing, say, an imported case of Ebola or Marburg in the state?
First, I will answer the last question. That is Ebola or Marburg. We can identify if it comes to Kerala because we have got the databases are stored in the Gen Bank, and so we can do a next generation sequencing and it can be identified. It's not an unknown disease because it's there in African countries, Ebola and Marburg. Only if it's a disease X, there will be a query. How do we go about? That is in Kerala. If you are coming to Kerala, we have an Institute of Advanced Virology, Thonikal is coming up. If it's a viral disease that is going to come up. And we have next generation sequencing only available in institutes. For example, it's available, it's going to come in IAV as well as in Rajiv Gandhi, ISER. All these places only have your next generation sequencing is available. So we have to go for next generation sequencing to identify the pathogen. And for next generation sequencing, you need very expensive equipment, expertise is needed, bioinformatics expert also is needed. So that is not available as when we think about Kerala. It may be in 2 years, definitely we will be coming up with all the expertise, bioinformatics expertise. And because you all know, IAV Thonikal, it's going to come up, and BSL level 4 lab is going to come there. And therefore, we will have all the facilities to diagnose a disease X and not depending on National Institute of Virology, Pune. Because any disease we have to confirm with NIV Pune. Nipah also they identified, but we have to confirm, and only the NIV Pune has to identify it. So Ebola Marburg is no issue, we can identify. But in the case of a disease X, Kerala at present will not be able to do it as fast as it. Alone it cannot do without the help of NIV Pune.
Madam, you know that in 2023, the case of Nipah in Calicut presented as pneumonia and ARDS without any signs of encephalitis. And if you are looking at and searching for a disease X or an emerging pathogen, it is said that it's just like searching for a needle in a haystack. So in such a situation, so do you suggest a syndromic approach or a targeted PCR approach?
Yes, we will do a syndromic approach because we will know when the patient comes, how was Nipah identified in Calicut? Because based on the symptoms, and they found out that, okay, now Nipah was encephalitis, so what are the viruses that we have to look for the causative agent, and thus Nipah was identified. What else you want to know?
Regarding madam, for example, that patient just had symptoms of pneumonia and ARDS.
Okay.
So if you are going to test all cases of pneumonia and ARDS for Nipah, then it will be we have to test a lot of patients to find one positivity, right madam?
Yes. So we have got now syndromic approach, that is BioFire is available. You have got a gastrointestinal panel, joint infection panel, you have respiratory panel, pneumonia panel, meningitis and encephalitis panel, and blood culture ID panel. So 6 panels are there. There you not only identify fast your viruses, also you can detect your resistant genes also can be identified. With that turnaround time is only 1 hour. If you have that equipment, you can fast identify syndromic approach. Now with one more thing about targeted NGS, that WHO has endorsed targeted NGS as for the final identification of Mycobacterium tuberculosis. We have now pre-XDR, XDR, tuberculosis. So we have got targeted NGS. That is the latest. It has come. WHO has endorsed so that we can find out the drug resistance for about 15 drugs by using targeted NGS. And advantages of targeted NGS over NGS is that directly from the sample you can do targeted NGS.
Madam, in 2019 December, so there was a clustering of pneumonia in Wuhan, and they identified it as novel coronavirus only through sequencing. Correct. So like that, suppose we are having a clustering of pneumonia without an etiology in, say, Trivandrum. So will you select a targeted NGS or an whole genome sequencing?
Targeted NGS we cannot say. We have to go for whole genome sequencing. Because targeted means we know that this is the target that we are looking for, that we cannot go. So we have to go for WGS. This I have told earlier.
Exactly. So basically, if you want to diagnose disease X, we need to have whole genome sequencing, and targeted NGS is not going to work. And as Madam started her talk by saying that pre-test probability is going to be the key. So we need to look at the epidemiological factors, the clinical factors, the anthropological factors, the immune status, the host susceptibility, the test characteristics, and based on that, we need to see whether we can go in with a syndromic panel or a targeted panel or targeted NGS or whole genome sequencing, etc. So with that, I would like to ask the panelists regarding, so you have touched upon all aspects of antimicrobial stewardship, all aspects of advances in the field of infectious disease, vaccinology, immunology with regard to sepsis, the testing strategies, etc. All these things, what all things have come into the practice guidelines per se. So one aspect is the team effort. Last year, 2023, the European Society of Cardiology came out with this infective endocarditis guidelines. So they said that if you want to optimize the outcome in a patient with endocarditis, you need to have a team, and they termed it as the heart team, comprising of the cardiologist, cardiothoracic surgeon, ID specialist, the clinical microbiologist, the radiologist, nuclear medicine person, everything together. So like that, of the things that you touched upon, so what all have led to a change in the practice guidelines?
Okay, so just like IE guidelines where there's a teamwork required, even for diabetic foot infection, it was beautifully put forward that there is a teamwork that's involved. Okay, so for ID, personally, we are the link actually. We primarily we are giving inputs to multiple and bridging multiple people. So for any infectious disease, there's a teamwork, and we'll be part of any of the team that involved in any complicated infection, be it bone and joint, be it implant infection, and we work close with microbiologists. Our day begins with contact with microbiologists, with their microbiology report. Our round starts, so that's our backbone. So they are our backbone, and for any complicated infection, we form a teamwork. And antimicrobial stewardship itself is a teamwork, because to run a good antimicrobial stewardship on the ground, you need a team. In our practice, we have a team which includes clinical pharmacists. She does a beautiful work. She's actually, in 2 months' time, she's better than a doctor, because she knows what we expect from microbiology. She does the preliminary basic clinical work of how sick the patient, and bug drug match she does beautifully, and the interactions and drug dosings and appropriateness. So she's a steward. So we, as a steward team, we have multiple people, including IT and ICN and clinical pharmacist. So teamwork is important, and I feel in the coming days, the AI inputs to clinicians is very important. So AI can help tweak the clinical decision making of a clinician. In any hospital, it is very difficult to educate. Education is part, but it is actually, when you look at that pyramid, it is the least effective one. Education. Education is important. Whatever has a automated system, that will have the most effectiveness. In the sense, if you have a system working, a new 60 students joining a hospital or an institution, you can give education, but only 30% will come in, go across their head and they will register. But if you have a system, that will make them learn and do also. So clinical decision making system is the way going forward. If you have to do, tweak the clinician or nudge the clinician, be it surgeon, clinician, to choose the right test for the right patient and give the right treatment. So CS clinical system is actually based on, we can make in our EMR system, but it is all based on information that we give, and nudging is all in the EMR. So that is the way forward, and AA is going to play an important role for our team work, and they will help every clinician in their day-to-day decision making. And we have a large data to guide us to differentiate between granuloma, which is sarcoid, and TB. We have large data which will predict sepsis based on sepsis predictor genes, patient genes, as well as the lab parameters. So this is called genomics. So this is also coming in a big way. We have a large data bank existing, and people are selling data like Stanford. So they are selling the data based on which you can actually make predictions for your population and validate, and then probably it can be rolled out. So this is prediction models are going to be the future. This all probably we have to imbibe. It may be tough for us, but we'll have to get some help from AI in learning and actually refining ourselves, I should say, and make error less error. I can't say error free. So that will be the way forward, and that's what I feel.
I think for me, if you ask the impetus, I would rather newer things. I would rather want to emphasize the older things, because as a postgraduate, the amount of blood we would take from a child would be just which changes the color of the culture medium. Now we are more sure that you want to take at least 2 ml for a newborn and 10 ml for a child 10 kg. So getting that amount correct so that madam can give us a report has changed. And of course, sending cultures, definitely we were always backward, we have come forward. And antimicrobial stewardship, yes, that has come as a big way. And of course, getting that molecular diagnosis, we still don't have access to it, even though we read, and it's not very freely available for us. That is whether it is KPC or whether it is OXA48. But still, you have data telling you which are the prevalent genes in the community and which is the resistance that you are going to anticipate, and that has definitely helped, especially with the ICMR data that comes out giving you a profile. And when we compared with the antibiogram of our hospital, it's almost similar when the ICU data in ICMR as well as ICU data in the institute. So that is one boon, because now the microbiology department gives you the antibiogram for you to fall back on. Another thing regarding molecular diagnosis, yes, nowadays we are routinely sending for the nasopharyngeal swab or a ET aspirate for a viral PCR, which helps you to diagnose what it is. So that if your child is not doing bad, you don't go for a knee-jerk reaction of upgrading the antibiotic. You know that there are viral infections where CRP is positive. It's not only adeno. You can have a bad influenza with CRP positive. You can have an RSV with CRP positive. And you know that these are infections which are going to be there for 10 to 15 days. The baby will be there in the ICU. So once you get those diagnoses, you are much more laid back. So newer diagnostics have helped us like stopping us from escalating antibiotics unnecessarily. I think these are some things that has happened recently.
So if you have money that madam has now told about resistant genes, we can do it fast. If you have a gene export machine, you can have a CARBA-R, all these genes can be detected very fast. 1 hour you get all your resistance pattern also. But money is an issue for us.
Thank you very much for this opportunity, and I would like to reiterate what Shrija madam said, that the focus has to be on the basics. Even with all the advanced vaccines and all, now we are actually struggling with increasing the UIP uptake, etc. So the goal lies in the basics. Thank you very much for the opportunity.
It's very rare to find so many microbiologists. Locally eluting antibiotics. See, one of the pictures Niju showed was injecting some local antibiotics. What is the role of local antibiotics in a diabetic food as well as in a when you are putting an implant? Does it have any role? There are so many panelists here. No, that's what they said. Injectable antibiotics. No, I think at foreign people said the local is much better than any oral.
Actually, no, they are going away from systemic antibiotics. Means that systemic antibiotics means there is an alteration to the gut microbiota and the resistance will occur. So you want the antibiotic concentration at the site of infection, and that is why they are coming with all these models of locally eluting antibiotics, etc.
This is called antibiotic brachytherapy, like cancer therapy. It is called antibiotic brachytherapy. It is being used for implant, where you can use in implant, you can put it in like cholesterol. They have formulation, they have how much of grams to be used, all those are available. For diabetic infection, that they have said they have used some calcium thing that I am not aware. Bone cement. So it should be the same, but I don't know whether it is practiced here, but it is a definitely. I was actually very, very interested on that, because we know that none of the antibiotics that you give IV reaches there, because they always have POVD. So whatever we give, we don't know how much they reach the bone and effective. So a local therapy definitely will be a thing that we have to consider. It should be possible. Probably we have to see how they have there. If they have a formulary for that, we should just duplicate or replicate that. Only thing, almost all antibiotics, whether all antibiotics can be given that way, we have to see what are compatible and so on. And
I have one question. I think during my days, some of the smoldering infections which could not be controlled. I think the patient was put on chronic suppressive therapy, ciprofloxacin, and all for months. Some infection of the microbial which you have not been able to detect even on a transesophageal level. Because if you start the antibiotic, there is recurrence. So they have put on chronic suppressive therapy long term to continue. Is that exist now? Smoldering
without
infections.
a site of infection.
Now that you have the resistance or patterns and all, no? So whether the things are different now. This is talking about my days in 1990 and other things. Has it changed now, where this chronic suppressive therapy can be gone to definite curative therapy to eliminate a chronic smoldering infection?
Is it for a urinary infection or just an infection? Okay, valve infection.
So there
Yes.
we could not identify any
Yeah.